So just checking can people see a PowerPoint? Whoops, I'm right at the end of mine, aren't I? Let's go back to the start.
Yeah, we could see that fine though.
Sorry, my start and slides look very similar. Okay. So yeah, my name is Ravi. I'm a teaching fellow, and last year I spent 6 months working on a pediatric cardiology ward. So I thought it'd be a good idea to do this session on pediatric cardiology and congenital heart defects. Namely because when I was an undergraduate, I found it quite a murky topic. I think when I first, well, my main memory of pediatric cardiology was, right, firstly, I didn't know cardiology too well. Secondly, it's all to do with things like murmurs. Then kids have weird anatomy, so you can't even take normal anatomy for granted. And then there's a lot of neonatal cardiology involved. And generally, it just seems like quite a scary topic when you just stitch it all together. And like a lot of it is not very much drug-based, but it's about just knowing about all these anatomical variations. So I found it very scary. That was literally me until I actually did this job. And then I think a lot of it became quite clear quite quickly. So what I hope you get out of this session is that this session is designed to be an application of knowledge, okay? And what I hope to show is that a lot of what we would ask of you at undergraduate level for pediatric cardiology is mainly having an understanding of what's happening with the heart and what the abnormality is. No one's really going to ask you much about treatments in most cases, and a lot of pediatric cardiology ends up being syndromic. So I think that's one of the big frustrations with pediatrics when people are first learning about some of the subspecialties, is that it ends up being a lot of lists and people are unsure which conditions are worth learning about. So hopefully I'll highlight a few of those here. I've tried to make it as simple as possible. So if nothing else, you can get some mnemonics and some handy shortcut lists for you to revise from. And it's not really meant to be a run through of undergraduate pediatric cardiology. So I hope there's a few guys attending this talk and watching it later on. It would help if you already had some introduction to the topic already. Yeah. But I will use some of the questions on here as a springboard to discuss some physiology and pathophysiology about what's going on, so you can help structure your learning as well. So yeah, I hope it's useful. So this series is going to be a set of 9 SBA questions, and we'll have a discussion after each question as well. So we'll start off with the first question. So over here, you've got a 2-month-old girl who's being and which sign would be most apparent on examination to indicate that she has congestive heart failure?
Five more seconds.
Okay, so we've got a good mix of answers here. No one's picked D, okay? And then there's a roughly even split amongst A, C, and E. Okay. So the correct answer here is hepatomegaly, okay? And we can run through this. So first of all, let's start off with the topic that we're discussing. So Faltering growth is when a child is not following the trajectory we'd expect them to in terms of their weight and height percentiles. And there are a whole list of causes for this. Okay? One of the common, not necessarily common cause, one key cause that you need to think about is, could this be cardiac related? And if it is cardiac related, you need to try and find evidence of them being in heart failure before you send them off to have an echo. So in terms of what could indicate she's in congestive heart failure, so just like with adults, they can, but options A, B, C, and D all could happen in congestive heart failure. But bear in mind, this is a 2-month-old girl. So babies on the whole, they can become edematous, so they could have peripheral or sacral edema. However, they tend to be horizontal, yeah? So you would not often see fluid pooling to like the legs or the sacrum. So it actually becomes quite hard to see unless they become markedly edematous. That's also coupled with the fact that often these babies are often quite chubby, so it becomes quite tricky to see. And along the same lines with jugular venous distension, I think it's tricky to see it in adults in some cases, depending on like how small their neck is and if there's a lot of subcutaneous fat. And it becomes especially challenging to see it in a baby. Okay. So hepatomegaly is the correct answer here. It is actually palpating for the liver. It falls part of the pediatric cardiovascular examination. And it is really important that if you are examining that system, or you are concerned that somebody is in heart failure, that you do palpate the abdomen as part of your routine examination. And that becomes quite easy to do in children because they're a lot smaller, so you can actually palpate quite readily and quite deeply. Yeah. And often you can measure the progress of their heart failure in some cases by palpating them regularly every day while they're on diuretic therapy. And you can often then see the hepatomegaly reduce or increase depending on what their clinical course is like. Clubbing itself is not a sign of heart failure. There might be children who have heart failure that do have digital clubbing. However, you would not typically expect to see this in a 2-month-old, and it would predominantly be in children who have congenital cyanotic heart defects. Okay, so but clubbing in and of itself is not a sign of heart failure. Okay, so in terms of how children present and are identified with having various congenital defects, there's 3 main ways really. One of them is heart failure. Okay, and it's worth knowing about heart failure because in pediatrics, because it presents differently with different ages. Yeah. And as children get older, it starts presenting a bit similarly to how adults present, but there is a lot of variation. So it's worth knowing about these as it's a red flag sign. So typically with infants, classically they'll have feeding difficulties, and especially of note is that parents will report that they sweat while they're feeding. Now, on the whole, babies, especially very young babies, are immobile. Okay? There's not much physical activity for them to do, and they should be able to feed without much effort. So the fact that they're sweating while they're feeding is a really positive indicator for them being in heart failure. Coupled with this is faltering growth. So children with heart failure tend to have anywhere between 120 to 200% of their metabolic demand compared to normal. And as a result, if they are not getting extra nutrition, they will start falling off their centiles. Toddlers, it's a bit trickier to notice heart failure in, but the main things that you'll tend to see is parents reporting markedly reduced appetite, and they'll generally not be very active. So this is inconsistent with their developmental age. So you normally start seeing them being quite active. They'd want to explore everything around them. They'd want to play, but instead they're quite lethargic and tired, and they're not eating much. And then finally, when you get to older children, they're also a lot more mobile. So you would start seeing exercise intolerance in them, and be a lot more obvious than in, say, toddlers, because you'd be able to see older children run around. And one really important presentation with children in heart failure is when they run around, when they're forced to stop, they might actually have quite bad abdominal pain, and they may actually vomit as well, especially after exercise. And in that case, you should think of heart failure as one of your differentials. And then the latter 3 or 4 points are all in keeping with what you might expect with an adult. Yeah. But those are the main ways they would present in heart failure. And then the other way they might present is with cyanosis, and this can be due to their heart failure or due to a congenital heart defect. And then finally, another way children often identified with having some sort of heart defect is if a new murmur is heard. So this could either be on the newborn screen or at a later stage when things are incidentally heard, physical examination. And all of these things would subsequently lead to a cardiological workup, which in some cases might involve checking the BNP for signs of heart failure, but ultimately it will lead to an echo to confirm the diagnosis and characterize the anatomy better. Okay, so moving on to question 2. A newborn boy is said to have a systolic murmur during his newborn check. On gross inspection, he's noted to have a flattened nose, upward slanted eyes, and a large tongue. What is the most likely characterization of his murmur?
Five more seconds.
Okay, so most people have gone for pansystolic, which is the correct answer here. Okay. And the reason this is pansystolic is the clinical description of his gross appearance is in keeping with trisomy 21 or Down syndrome. And the most common defects people with Down syndrome have are septal defects. So you'd expect around at least 50% of people with Down syndrome to have some sort of cardiac involvement. And the vast majority of these will have a septal defect. So they will either have a ventricular septal defect, atrial septal defect, or what we call an atrioventricular septal defect. And these are essentially holes in the respective septa. So starting off with the type of murmur you might hear is with a ventricular septal defect is that it's a pansystolic murmur. And this murmur occurs because during systole, blood is being forced predominantly from the left ventricle to the right, and it goes straight to the defect. There are no valves for it to overcome, therefore it occurs all throughout systole. Yeah? So therefore it's a pansystolic murmur. Now, the atrial septal defect, is a murmur that occurs not actually due to this atrial, that doesn't actually occur due to blood flow going through the atrial septal defect. It actually is a flow murmur that goes through the pulmonary valve. And the reason this happens is because blood passively fills from the atrium, it flows from the atrium, during cardiac relaxation. So with the heart being tilted and higher pressures on the left side, it tends to go from the left atria to the right atria. But this is a low pressure system, so you wouldn't get a murmur here typically. But as a result, there's proportionally a lot more blood on the right side of the heart now because it's got all of the blood coming in from the vena cava, and it's also got some of the left side's blood going through the atrial septal defect. And this starts filling eventually into the right ventricle. So with there being relatively more blood in the right ventricle, as a result, during systole, it creates a flow murmur going through the pulmonary valve. and that's why it becomes an ejection systolic murmur. So if ever you hear a systolic murmur, or you're told that there is somebody versus systolic murmur and that they have a septal defect, you should be able to distinguish between atrial and ventricular septal defects based on the type of systolic murmur that exists. Yeah. And then finally, with atrioventricular septal defects, this is actually a spectrum of conditions that arise due to a hole both in the atrium and the ventricular septa. And depending on the severity of the disease, so this is something worth looking up if you're on Google Images, is depending on how the cardiac inlets go, you sometimes get a unified atria and ventricular inlet. So you sometimes get all your atrioventricular valves merging into one annulus. So you sometimes get a 5-valve connection between your atria and ventricles. And that's in its most severe form. And then as things become less severe, your heart anatomy starts becoming a bit more normal. But because there is a ventricular septal defect here, the pansystolic murmur will dominate. So you will, of course, get an element of ejection systolic as well. But because there's a ventricular septal defect, a pansystolic murmur will occur throughout the heart. And children with trisomy 21, the most common defect that they have is AVSD, so an atrioventricular septal defect. And then after this, they have a ventricular septal defect as the next most common defect. So regardless of which one it is, or even if you add the two together, a pansystolic murmur will dominate. Okay. And just quickly touching upon murmurs in children. So generally in terms of valvular murmurs, they have the same pattern as adults. So if ever you get told somebody has a pansystolic murmur or ejection systolic murmur, or it's a diastolic murmur and it's to do with the valves, you can use the same rules as you would with adults. The additional murmurs you might hear are things to do with septal defects, which we just covered, or a patent ductus arteriosus. Now, a patent ductus arteriosus has a continuous murmur and is often sometimes described as a machine whirring murmur. And this is occurring because the ductus arteriosus remains open, so there is a communication between the aortic arch and your pulmonary trunk. And because of the changes in pressures between the cardiac cycles and the changes of pressures in the aorta, blood will constantly be flowing through the ductus arteriosus. So no matter what's going on with the heart sounds, you'll still be able to hear a background noise. And if that's the case, you need to start thinking about a PDA. The one thing to mention with regards to children is that they often have a lot of innocent murmurs. Yeah? So compared to adults, a lot of children often have murmurs that are innocent and they're what we call flow murmurs. So children who are quite unwell, when they're in a hyperdynamic cardiac state, you'll often hear murmurs, and you can hear a murmur across all sites of auscultation of the heart. Yeah? And there is a mnemonic called the 7 S's of pediatric murmurs, and these can tell you whether a murmur is benign or not. But the one rule you should all be able to remember is that all diastolic murmurs are pathological. So if ever you hear a child with a diastolic murmur, they would need a cardiac workup and an echo. Okay. Things that also might reassure you about a murmur are that if it changes with position, so if you can get the child to lie down or squat and that changes things, that can reassure you. And also if the murmur can be heard across the heart essentially, rather than just in one place. Okay. But by and large, murmurs, the valvular pattern is the same as adults. And the two main extra reasons you would get murmurs are due to septal defects or a patent ductus arteriosus. So going on to question 3. So after noticing an abnormality of the aorta, ventricles, and ultrasound, a boy is delivered at a specialist unit. An echocardiogram reveals his aorta is interrupted, with his descending aorta connecting to his pulmonary trunk by his ductus arteriosus. a pansystolic murmur is heard on auscultation. And additionally, on examination, he was found to have a cleft palate. So with this description in mind, what genetic chromosomal abnormality is this patient most likely to have?
Five more seconds.
So main answer split between B and E. So let's go through this. So the correct answer is B. Okay. So a 22q11.2 deletion. And this is in keeping with DiGeorge syndrome. So if we go back to the question, the description here is describe what an interrupted aorta is. So just in case people have been learning DiGeorge syndrome and they think about buzzwords such as interrupted aorta and cleft palate. Sometimes if the question is to be made a little bit trickier, you might have just been told an echocardiogram confirms his descending aorta is connected to his pulmonary trunk. Yeah, and you need to interpret that to mean it's an interrupted aorta. And what we mean by an interrupted aorta, so if you start off with the normal heart, this is the normal aorta. And then these are examples of how the aorta can be interrupted. So the left ventricular outflow tract next to the aorta, that begins as normal. Depending on what happens and how much of the aortic arch is involved, you can classify things into three different ways. Now, you don't need to worry about the classification at an undergraduate level. That's not required at all. But this diagram here is just more to illustrate that an interrupted aorta, this is what an interrupted aorta looks like. Okay. Now, patients with DiGeorge syndrome, they have a variety of abnormalities, and it can be summarized with the mnemonic catch-22. Okay? So they have cardiac abnormalities, the most common of which is an interrupted aortic arch, and they usually also have a ventricular septal defect. Okay? So those are two main things you need to associate from a cardiological perspective. They also have DiGeorge facies, which you can take a look at. And of note is that they also have thymic aplasia. So this is really important when you are considering newborn babies, and if they potentially have DiGeorge syndrome, or if they have an interrupted aortic arch and you haven't done the genetic analysis on them, you need to make sure that if you're ever ordering blood for them, they need to have irradiated blood, yeah, until you fully can characterize their mutations and also their white cell profile. Okay, because if they have an absent thymus, their T cells won't function as well. They also have a cleft palate, that's part of the phenotype, and they often also have hypoparathyroidism, so you need to monitor their calcium soon after birth as well. Okay, and the genetic mutation underlying this is on chromosome 22, yeah, it's on the Q arm, and it's on the loci 11.2. Okay, but that pretty much summarizes all you need to know about DiGeorge syndrome at undergraduate level. Okay. So a reference table here for you guys, okay, is when considering certain syndromes and genetic defects and cardiac involvement, these are the main ones I think you should focus on when revising for exams. Yeah, so for trisomy 21, it'll be septal defects, and an AVSD is the most common. Whereas with trisomy 18, once again, it's septal defects, but it's an atrial septal defect, which is most common. And the important thing you need to bear in mind is often you'll get told just a singular association between a particular genetic defect and that cardiac involvement. But just bear in mind, it's often not just one singular finding. There are often a variety of findings, of which one might be the most common. Yes, so going along the lines of that, with DeGeorge syndrome, an interrupted aortic arch is the most common, but they also could have tetralogy of Fallot. Yeah, Turner syndrome, so 45X0. Yeah, these women often tend to have a bicuspid aortic valve, and they could also have coarctation of the aorta. However, the most common finding is a bicuspid aortic valve, where 1 in 3 tend to have that. And interestingly of note is that both of these can produce a systolic murmur. It's just bicuspid aortic valves tend to produce a systolic murmur much later on in life, as they tend to, I think they tend to calcify much more easily, whereas the coarctation of the aorta tends to produce a systolic murmur from the get-go because it's a stenosis. Yeah. And prolonged QT syndrome, there are a variety of mutations that can affect a variety of channels on the cardiac muscle. Most tend to implicate potassium channels. And the key thing to note with that is if you have prolonged QT syndrome, you need to bear in mind that there is sudden risk of cardiac death due to ventricular dysrhythmias in particular. Yeah. So these are the patients where you need to be careful about prescribing things like macrolides and certain antiemetics and so on. And if you are going to do so, you need to do an ECG beforehand and regularly monitor their ECG just to make sure their QT segment does not prolong. Question 4. So a newborn boy is noted to have an abnormal face. His upper lip is thin and is accompanied with a smooth philtrum and a small jaw. He's additionally noted to have a pansystolic murmur. Which risk factor best describes the boy's examination findings?
Five more seconds.
Okay, so the vast majority of people have gone for C, maternal alcohol consumption. Well done. I thought this was quite a tricky question, actually. It turns out you guys probably know it quite well. So yes, so this child, the question was describing the phenotype for fetal alcohol spectrum disorder. Okay, and one of the key giveaways is a smooth philtrum coupled with a pansystolic murmur. Okay. And there are a whole variety of antenatal or like in utero risk factors for congenital heart defects. These are the ones I would say you need to know. Okay, so in terms of drugs, the main ones you need to know about are lithium, which is Epstein's abnormality. And the key thing to note from that is you should know that what Epstein's abnormality actually is. So not just the word association, but essentially it's where your the leaflets to your atrioventricular valve on the right-hand side tend to be lower, and as a result, you get a degree of regurgitation. from your right ventricle to your right atrium. And this tends to really dilate your right atrium in particular, and that's what we call Epstein's abnormality. Yeah, so we sometimes say it's atrialized. And then when it comes to alcohol, the main risk factor there is fetal alcohol spectrum disorder. Okay. And that's with the phenotype described earlier. And it's well worth looking into how the phenotype manifests and how broad the spectrum is. But these children often have various neurological complications as well. They often struggle to maintain their attention. And it actually does have quite profound impacts. And there are lots of videos on YouTube where you can see interviews with parents as well as children themselves on what it's like to have that condition. More smaller print, so less important in terms of focusing for your exams, but worth knowing about is that cannabis is not risk-free when it comes to pregnancy. It can confer defects, congenital heart defects upon the child, and the most common of which are septal defects. Okay. Now, in terms of conditions affecting the mother, the key thing to note is probably the first one most importantly, is if a mother has a diabetes mellitus, firstly, they're at a much higher risk of giving birth to a much larger baby, but they're also at much higher risk of their baby having transposition of the great arteries, which is a very serious cyanotic heart condition, okay, where your aorta and your pulmonary trunk switch their insertions. Yeah. Maternal rubella can cause pulmonary stenosis and is associated with patent ductus arteriosus as well. Yeah. And this is one of the main reasons why we tend to vaccinate both boys and girls against rubella, just to try and minimize the risk of transmission to pregnant women, essentially. And lupus, if the mother has lupus and is anti-Ro positive, that can result in complete heart block in the newborn. And depending on how severe the heart block is, in some cases it can be reversed, but in other cases, it may result in that child needing a pacemaker from the get-go. Okay. And then hydrops fetalis, you can view it sort of similar to like almost heart failure in utero. The main risk factors are maternal infections, especially viral infections. The key one to know about is parvovirus B19. Iron deficiency anemia can do it, and also preeclampsia. Okay. But this slide here should contain a lot of the key antenatal risk factors for congenital heart defects, at least for undergraduate level. Okay. Of note, I think someone did pick opioid. So opioid abuse doesn't typically tend to result in cardiac abnormalities, but you would tend to see something called a neonatal abstinence syndrome, where they effectively are born addicted to opioids. They're born dependent on opioids, and they then start experiencing withdrawal symptoms. Okay. So, going on to question 5. A 6-day-old girl is brought to hospital by ambulance after her parents found her face had turned blue. She had an unremarkable birth history, and despite being on high-flow oxygen during the ambulance ride, saturations remain at 82%. Her airway and chest are clear on examination. What is the most likely diagnosis?
Five more seconds.
Okay, so most people have gone for option A, transposition of the great arteries, and that is the correct option. Okay, so the key thing to note over here is both the girl's age, and this description of her saturations remaining at 82%. So she does have a cyanotic condition. The reason she turned cyanotic at 6 days old was likely that she had her ductus arteriosus closing, which is providing a very useful shunt to her systemic circulation. And as a result of that closing, it unmasked the transposition of the great arteries. So these children are usually, like the vast majority, so over 75 to 80% are diagnosed antenatally. And if they're diagnosed antenatally, they can be, they're born at a specialist center, and then they're immediately put on oxygen support and so on. Okay? However, there are a small percentage that aren't, and when they are born, it's still missed, because transposition of the great arteries doesn't tend to come with a murmur. And even if they do come with septal defects, sometimes if the septal defect is large enough, that provides a useful shunt. They might have normal saturations, and they might not have a murmur due to having quite a large septal defect. Okay. And the important thing, which we'll come on to on the next slide, is no matter how much oxygen you give, the saturations won't rise much or at all really, because you effectively have two parallel circuits going on with regards to the circulation. Okay. And while we go through this, I'll quickly run through what each of these defects are. Okay. And this is the one thing that's worth knowing about in pediatric cardiology is if you can summarize each defect within one sentence, that'd be really helpful with understanding what's going on. And that's probably all you need to know about them in most cases, because no one's really going to ask you much on how to correct them, okay? Namely because in lots of cases, the procedures that are done to correct them vary between center to center. So a patent ductus arteriosus, you should know that the ductus arteriosus connects your pulmonary trunk to your aortic arch. And it's really useful in utero because it provides a shunt that bypasses the lungs. Once you are born and you have a normal newborn circulation, the ductus arteriosus then basically involutes to become your ligamentum arteriosum. Okay, but a patent ductus arteriosus, importantly, is not a cyanotic heart defect. Okay, so this should not be an option. The truncus arteriosus, the best way to think about this is that it is a single channel that takes blood from both the left ventricle and the right ventricle. So for those that are interested in embryological development, what happens is you actually have this single vessel, the truncus arteriosus, and it tends to then septate along the middle and spiral, and that's what then forms your aorta and your pulmonary trunk. But if for whatever reason that septation does not happen, you then have a single channel going out of the heart. So this would be a cyanotic heart defect. So it could explain why she is blue, but you would expect that to not be unmasked at 6 days old. You'd expect that to happen from birth. Okay. Total anomalous pulmonary venous drainage. So you might see that as TAPVD. That should be quite self-explanatory when you look at the name, but it's saying the pulmonary vein is basically where the pulmonary vein drains anywhere but where it's meant to, okay? So normally you'll have the pulmonary vein draining into the left atrium. If it connects anywhere else, basically that is anomalous pulmonary venous drainage. Now you can have several pulmonary veins. So what total refers to is as to whether it all drains into the wrong place or whether some of it might drain to the correct site. Okay, but this could be a cyanotic defect. But once again, you'd expect to see it from birth. And then coarctation of the aorta is a stenosis of the aorta. So there is no shunting taking place here. So as a result, you would not expect this to be a cyanotic condition. Okay. So hopefully you can, if you have an understanding of what each of these are, coupled with the age of the child, you should be able to get the correct diagnosis, and that can be reinforced with the information about the saturations. Okay. So continuing on, so you now have a 1-week-old baby boy who's got transposition of the great arteries, and he's awaiting corrective surgery. Okay. He is on a prostaglandin E infusion, yeah, and is alongside and has a nasogastric feed as well. And the aim is to optimize his weight and let him grow prior to operating. So the prescription of which drug would most likely cause him to deteriorate?
Five more seconds.
Okay, so once again, the vast majority have got this question correct, but everyone has, all the options apart from E have been picked. So we'll go through this. Okay, so the correct answer is B, ibuprofen. Okay, so talking about transposition of the great arteries in particular, is that it is what we call a duct-dependent lesion. Okay, so survival is heavily dependent on you trying to keep the ductus arteriosus open. So talking about some pathophysiology now. Okay, things that maintain ductal patency, yeah, are prostaglandins and a relatively low concentration of oxygen. Okay, so this is what happens in utero. These are the two things that maintain the ductal patency. The bulk of the prostaglandins come from the mother. Okay, they're maternal prostaglandins. Okay, so once the baby is born and you then separate the baby from the mother, you lose the maternal prostaglandins. And once the fetal circulation transforms to the newborn circulation and the first breaths of life are taken and the arterial supply has a much higher concentration of oxygen compared to the utero supply, these then act, the stimulus to keep the duct open are gone. And this in turn gradually makes the duct close. Okay. Now, from a pharmacological perspective, you guys should know that ibuprofen acts on your, is a cyclooxygenase inhibitor. And that in turn acts inhibiting, I believe it's the conversion of arachidonic acid to, along the pathway to prostaglandins, okay? So this child in particular is on prostaglandin E, so children who are duct dependent, we give them prostaglandin infusions, yeah, to keep their duct open. So if you are then to give ibuprofen, this would start counteracting some of the systemic prostaglandins that the child already has, and it would increase their risk of the duct closing. Therefore, it's a contraindication. Okay. So the way I like to remember it is physiologically, prostaglandin E or prostaglandins will maintain the ductal patency. And then you should know from your pharmacology that NSAIDs will inhibit prostaglandin synthesis and therefore is contraindicated, okay? So that's how you balance the two together. Now, going through the other drugs, so dexamethasone, that wouldn't do it. We do give dexamethasone to babies, well, you normally give it to the mother who are premature, okay? So that helps with lung maturation. This child actually might need dobutamine, so if they go into heart failure, you might actually need to give them an inotrope just to maintain their cardiac output. Furosemide as well might be useful in this child if they, once again, go into heart failure, need to offload fluid, that can do it, and that's very helpful. And then ondansetron, it'd be unlikely for you to be giving ondansetron to a baby, but there is no reason why this in particular would jeopardize their condition, okay? So the best answer is ibuprofen. So given the last two questions are based on transposition of the great arteries, it's worth talking about this. If there is one cyanotic condition you know, it has to be this one. And I think it's a really good one to know because it's such a pure, it's like as pure a cyanotic heart defect as you can get. So this is your circulation. This is a normal circulation here. So you get deoxygenated blood coming in from the body, going through the right side of the heart, going to the lungs, and then going to the left side of the heart, and it has this effectively a series circuit, okay? What happens with the transposition of the great arteries is that your aorta inserts into the wrong place. So normally your aorta, should insert, to your left ventricle, but instead it inserts to your right. And vice versa with the pulmonary artery, okay? And that connects to the left side of your heart. And what this then results in is exactly two parallel circuits as mentioned earlier. So you then have deoxygenated blood going from the body into the right side of the heart. Critically, this then goes to the aorta and then goes back to the body. It does not go to the lungs at all. So you purely have deoxygenated blood in your systemic circulation. On the other side, you've got oxygenated blood, coming from the lungs, going to the left side of the heart, but instead of going to the aorta and going to the body, it instead goes via the pulmonary artery and back to the lungs. So pulmonary circulation is oxygen rich. So this in and of itself is not compatible with life, as I'm sure you guys can easily appreciate. So the key to maintaining survival is by having shunts. So at minimum, you want there to be a connection between the pulmonary artery and the aorta. And that is what we call the ductus arteriosus. So you want that to be kept open, if nothing else. Fortunately, for a lot of these children, they are born with usually another septal defect, either an atrial or a ventricular septal defect, sometimes both. And as you can imagine, the more mixing and shunting they have, the better, because you really want as much of this blood to go into the systemic circulation. And the corrective procedure for this is called an arterial switch. So what you effectively do is quite a big operation, but you swap these great vessels around and you sew them on. Okay. The challenge is that these babies are very small, and that makes the procedure technically all the more challenging, let alone, pediatric heart surgery is already quite complex, but doing it on newborns is especially complex. So what people try and do is ideally you want this operation to be done as soon as possible. You need to balance that against surgical outcomes and the ease of the operation. So what tends to happen is a bit of a balancing act where you try to make sure they don't decompensate and go into heart failure, but you also want to feed them and help them grow so that things are a bit bigger, they put on a bit more weight, they're a bit more healthy, and they also have more of a reserve to withstand quite significant heart surgery. Okay. So as mentioned earlier, with transposition of the great arteries, it's as pure a cyanotic condition as you can get. You need shunting to maintain life. The more shunting, the better. You maintain ductal patency by using prostaglandin E. So we use synthetic prostaglandin E. And you might get told prostaglandin E1 or prostaglandin E2. As far as you're concerned, they're pretty much the same thing. You can give them IV and it works brilliantly. And definitive treatment is the arterial switch operation, okay? So prostaglandin E is more a stopgap until you can actually do the operation. An important aside to know about prostaglandins is that, yes, they're part of your inflammatory response, okay? And this then makes it quite tricky in the newborn to determine if they've got an infection or not. Because when you give prostaglandin, it also exerts other physiological effects around the body, and that includes generating a temperature. So when you have a newborn on prostaglandin E who then spikes the temperature, you then have to be very careful with how you investigate the child and your clinical judgment about how the child is to determine whether you need to go down the full septic screen route or whether it's just an effect of prostaglandin E, because you cannot keep investigating every temperature spike that happens. Yeah. So the other things you would need to consider are whether there are any maternal risk factors for sepsis and whether this would be then conferred to the child or not. Okay. Now, cyanotic lesions. There are a lot of cyanotic lesions. If it is of any help to any of you, a lot of them begin with T. Okay. So, as I said, it would be really helpful if you do actually can summarize, if you are able to summarize each of these with just one sentence. Yeah. And that in turn should allow you to work out eventually whether it's a cyanotic or acyanotic lesion, just going from first principles. Yeah, so we'll cover tetralogy a little bit later, but we've spoken about TGA and truncostereosis. We've spoken about TAPVD. Now, tricuspid atresia is essentially a dead end. Yeah, so atresia means something that hasn't developed. So this is where your tricuspid valve hasn't developed, and therefore blood can't get to your lungs. Okay, and similarly, you could also get pulmonary atresia as well. And these are the common cyanotic defects to know about. But just bear in mind, this list is not exhaustive. There are a lot more, but these are the ones that are worth knowing about. Okay. So going on to question 7. A baby boy is seen at the GP for a 6-week check. He's noted to have a pansystolic murmur on his newborn check and is awaiting an echocardiogram. On examination, the murmur persists and a new finding of weakened femoral pulses is found as well. The rest of his newborn check is normal. He's tracking well on his growth charts and his mother reports no issues. Given the most likely diagnosis, this defect is left untreated. Which of the following complications are most likely to occur?
Another 5 seconds.
Okay. So I've got a broader mix of answers in this one. I think most people have gone for A, and a fairly equal mix for B, C, and E, and then some for D. Okay. So the correct answer here is actually C. Okay, so well done for those of you who picked C. This is a trickier question because it requires slightly deeper knowledge about what's going on pathophysiologically and long-term implications of a congenital defect. Yeah, so we're going a bit deeper now. So, information we have is there's a baby who has a pansystolic murmur, okay? and they're currently waiting an echo. Of note, he now has weakened femoral pulses. Okay. So if you come across a baby with weakened femoral pulses, the key thing to think about is that they might have, or probably do have, coarctation of the aorta. Okay. So that's our baseline. So that's the clinical information you need to extract and synthesize from the stem. Okay. Now, going on from that, the question is asking, if the defect is left untreated, which of the following complications is most likely to occur? So going through these one by one, just so you know what they are. So Eisenmenger syndrome is an acquired right to left shunt. Okay, so this typically occurs with patients with things like ventricular septal defects, yeah, where if left untreated, the higher pressures from the left ventricle pump more blood to the pulmonary circulation. This causes fibrotic changes because it's not built to cope with high pressures. And as you then start getting fibrotic changes, there's more resistance in the pulmonary circulation, and therefore the path of least resistance is actually for the blood from the right side of the heart to in fact then go to the left. And over time, this can then result in you becoming cyanotic, yeah, and also developing clubbing as well. So that's Eisenmenger syndrome. Yeah. Noonan syndrome is a congenital syndrome which has cardiac involvement. So that is not something that would be a complication that was developed. You'll be born with Noonan syndrome. Cerebral aneurysms, so those are swellings of blood vessels in the brain, which we'll come on to in a second. Cyanotic spelling is something that occurs with patients with tetralogy of Fallot. Okay? And I'll discuss this later on when we come on to discussing that condition. And ischemic stroke is, well, I'm sure you guys already know, but interruption of the blood supply to the brain. So, with coarctation of the aorta, what the reason this presentation occurs, well, the reason we see this presentation with the patient of weakened femoral pulses at the 6-week check, but not at the newborn check, is that the ductus arteriosus is closed in the 6 weeks. Okay? And this in turn sometimes causes the aorta to narrow just a bit more, but it also minimizes how much blood is then going to the distal aorta. Yeah, so this can then help reveal the stenosis. Okay, so that explains why the femoral pulses are not seen in the newborn check, but seen later on. The weakened femoral pulses are not seen in the newborn check, but seen later on. Now, the implication of this is that with a stenosis in the aorta, the perfusion pressures distal to that stenosis, yeah, are lower. And this in turn means that your main apparatus for measuring blood pressure, yeah, and helping regulate that, or one of the main ones, is by your kidney, the juxtaglomerular apparatus, if you think back to your physiology. And if that detects a lower perfusion pressure, right, it triggers your renin-angiotensin-aldosterone system, which in turn increases water retention, but it also, and in turn, it increases your blood pressure. Yeah. The issue here is that that system is primarily built for hypovolemia, but in these patients, it is not an issue of hypovolemia. That's the reason why the perfusion pressure is low towards the kidneys. It's actually due to the stenosis. So what then happens is your blood pressure tends to increase. However, due to the stenosis in the aorta, that cannot be overcome just with higher blood pressure being given with higher blood volume, yeah, higher circulating volume. So as a result, what you then often tend to find is these patients, if you measure their blood pressure on their arms, they're hypertensive. And with blood pressure being quite high prior to the stenosis on the aortic arch, it means that your cerebral perfusion pressures will be very high. And this in turn increases your risk of aneurysms forming in your cerebral circulation. Okay. I'll just go back a bit just to see if that can be explained a bit more clearly. So just using this diagram here. Normally, the stenosis on coarctation of the aorta happens just over here, okay? So it happens just after the ductus arteriosus connects to the descending aortic arch. So when there's high blood pressure, you will get high blood pressure going to your upper limbs, but also to your left internal carotid and your right internal carotid, which comes off the innominate artery. Yeah. So that's why you get high blood pressures going towards the cerebral circulation and the aneurysms forming. And then obviously if your cerebral aneurysms are not picked up or treated, that has profound risk, and that can actually make you have a hemorrhagic stroke rather than an ischemic stroke. Okay? So I hope that was clear, but it all pins back to some quite basic pathophysiology with regards to blood pressure monitoring, yeah? Which hopefully makes sense. Okay. So as mentioned, coarctation of the aorta is narrowing of the aorta, and some of its complications can include hypertension. It can result in heart failure. So if your heart is now having to work a lot harder to try and maintain perfusion pressures across the body. Yeah, so this can then lead it to give out. You could get claudication. So this often presents, so often you see very young children, just as they're starting to run, then start complaining that their legs hurt. And that once again is due to the narrowing of the aorta, and it impairs appropriate blood supply reaching the lower limbs when they're metabolically active. Yeah. And then any sort of lesion. So there is also a risk of hyperperfusion after the narrowing of the aorta. So depending on how severe the narrowing is and where it is will depend on what parts of the body are hyperperfused, and that in turn can do respective damage to the target organ. But once it's detected, you usually do interventional radiology intervention. So you often do an angioplasty just to dilate it, and you may also do a stent as well. Okay, so this is very much in the domain of interventional radiology now. You may need vascular surgical involvement in some cases, but it's rare. Okay. Question 8. So you have a newborn boy who is cyanotic from birth. His cyanosis worsens upon crying, and on examination, his chest is clear, but his systolic murmur can be heard. An excerpt from his transthoracic echocardiogram is listed below. Yeah. So it says his atria are of normal size, his atrial septum is intact, his ventricles are of normal size. He's got a large ventricular septal defect with an overriding aorta. The aortic arch itself is normal, and the accompanying ECG is normal as well. There is some stenosis to the right ventricular outflow tract above the pulmonary valve, and there is a ductus. The ductus arteriosus is present and patent. So which finding from the echocardiogram is most important in determining the severity of this patient's cyanosis?
Five more seconds.
So most people have got this correct. Yeah, the answer is C. So what is being described here is a newborn baby with the key structural features of tetralogy of Fallot. Okay? They also have a patent ductus arteriosus, but you'd expect that with a newborn baby, yeah? And that's not part of the tetralogy. The one finding that's not seen here from the tetrad is right ventricular hypertrophy, which we'll go on to in a second. Okay? So the ventricular septal defect, the overriding aorta, and the right ventricular outflow tract obstruction are all part of the tetralogy of Fallot. Patent ductus arteriosus is just a physiological finding that you would expect to see in a baby of this age. And then the right to left ventricle thickness ratio it's not really a thing. Okay? So, as we mentioned here, the tetralogy of Fallot, it consists of 4 features. Okay, so starting off, you will have a VSD. Now, this usually needs to be quite a large VSD. So we typically say it needs to be larger than the annulus of the aorta. Yeah? So it's quite big. And then coupled with that is what we call an overriding aorta. And when we talk about an overriding aorta, what that means is the tract leading to the aorta hangs above the right and the left ventricle. And the reason it is allowed to be overriding is because of the VSD. So if the septum was intact, your aorta would not be able to go over the 2 ventricles, okay? So, and then coupled with these, you get a right ventricular outflow tract obstruction. Now, depending on who teaches you and depending on what books you read, you might sometimes see this just simplified to pulmonary stenosis. Yeah. But a right ventricular outflow tract obstruction is the most appropriate term because you can get stenoses occurring, or you can get the obstruction happening at the valve, above the valve, or below the valve. Okay, it's some sort of outflow tract obstruction anywhere along that tract. Okay, and the final one is right ventricular hypertrophy. And I put that in brackets because it will take some time for this to develop. Okay. The right ventricular outflow tract obstruction, yeah, in turn forces the right ventricle to work a bit harder, yeah, and that is what results in the hypertrophy, yeah. So you might not see the tetrad straight away. Now, out of all of these features, the main determinant of severity for the cyanosis is the outflow tract obstruction, okay. And that's because the VSD itself is quite large, okay? And with the VSD, physiologically, you know from earlier on that it is a left to right shunt. Therefore, that is not the main feature of what would determine whether someone's cyanotic or not, yeah? VSD in and of itself is acyanotic. Now, the overriding aorta, once again, that in itself won't matter too much because the VSD is so large that what will determine the way blood goes is the pressure differences between the 2 chambers. And the key thing that will determine the pressure changes between the 2 chambers, the pressure gradient between the 2 chambers, is this outflow tract obstruction. So the more severe it is, the greater the resistance will be, and at some point it'll be easier for blood from the right side of the heart to go across this very large VSD and to an overriding aorta already, and go up through the aorta. Yeah. The other thing to mention about, the important thing to mention about children with tetralogy of Fallot is that they have something called PET spells. And this is sometimes what's known as cyanotic spelling. And this is actually potentially fatal. But what tends to happen is whenever children are quite distressed or they start crying, it causes a change in their pressures. And we don't quite know why sometimes, but I think there is some hypothesis that your right ventricular outflow tract or certain parts of it start having some vasospasm. And this then changes the resistance. Yeah? And as a result, it makes this, it increases the severity of this obstruction. And that in turn leads to a sudden increase in deoxygenated blood going through the aorta. Now, this becomes a problem because when deoxygenated blood goes through the aorta, it triggers your chemoreceptors. Yeah? And because they detect deoxygenated blood, you start to physiologically respire more deeply and more frequently. Now, physiologically, if you had a normal heart, that would be great because it would encourage you to breathe more and it would encourage more gas exchange. Yeah, and it would correct the problem. The issue is that it is not a pulmonary problem here. It is due to shunting. And the increase in breathing actually results in more blood returning to the heart. It increases your right ventricular output and it results in even more blood then going from the right side of your heart to the left side of your heart. Yeah? And that then becomes a vicious cycle because if then more deoxygenated blood starts going, you then start breathing even more heavily. And it becomes a very vicious cycle. So it's really important that these children are not distressed, yeah, and that they are calmed down wherever possible. And there are things you can do, maneuvers you can do to try and help minimize that. Okay? But TET spells in children with tetralogy and fallow are a medical emergency. Yeah? And if anybody is interested to know about the first operation involving congenital heart disease, it was done on patients with tetralogy and fallow. Excellent film, something the Lord made. And it actually highlights how the story is about Blaylock, who is the surgeon. And he works with a pediatrician called Tossick to operate on the first babies who previously would have died. And he creates a shunt that's known as the Blaylock-Tossick shunt. But it was actually his lab assistant that did a phenomenal amount of work in developing the actual procedure and actually ensuring it was viable. But he didn't get any credit due to him being black. And there's work being done right now to actually not refer to it as a Blaylock-Tossick shunt anymore, but to refer to it as a Blaylock-Thomas-Tossick shunt, to give credit to Vivian Thomas, who initially wasn't credited with any of the work he did. But excellent film, well worth watching. And if you don't know the anatomy by the start of the film, you will know it by the end. Okay, and final question. So you have a 3-month-old boy, when corrected for gestational age, was born in May, and has trisomy 21 with a ventricular septal defect. He's currently on a high-calorie nasogastric feed and on furosemide. What prophylactic therapy is indicated for this patient?
Five more seconds.
Okay, a range of answers. No one's picked A, aspirin, which is good because we don't think he's at risk of any sort of ischemic damage. There's pretty much an even split between B and D, so palivizumab and penicillin. And then some people have also gone for cotrimoxazole and spironolactone. So what's going on here? So we have a premature boy. Now that he's corrected for gestational age, he's 3 months old, and he has trisomy 21 and in particular has a ventricular septal defect. The fact he's on a high calorie feed and on furosemide indicates he's already in some degree of heart failure. Yeah, you wouldn't put someone on furosemide for any other reason, really. Yeah, so he's in heart failure, he's premature, and he's got a congenital heart defect. So this makes him at extremely high risk of basically getting quite a serious bout of bronchiolitis. Okay, and the prophylaxis that we give for bronchiolitis is a monoclonal antibody called palivizumab. Okay, so the answer is B. Now, aspirin is what we use mainly in adults for ischemia and ischemic-related heart disease. We don't use it in children that often. The main time we use aspirin in children is in the context of Kawasaki disease. Cotrimoxazole, so we wouldn't really give that as prophylaxis. There's no reason to, from a cardiac perspective at least, to protect him from that front, and likewise penicillin. Patients who often get penicillin are those who are asplenic. And then spironolactone wouldn't be given as prophylactic therapy either, but it could be used as an adjunct for his heart failure if furosemide alone doesn't do it. Okay, and you guys are expected to know a bit about palivizumab. So it's a monoclonal antibody, and importantly, it is really important to explain this is not a vaccine. They need to have regular monthly subcut injections during bronchiolitis season. Now, it's important to say it's during bronchiolitis season, so it's caused by respiratory syncytial virus. But depending on where you are in the world will depend on when that bronchiolitis season occurs, okay? So obviously, if you're in the UK, it will pretty much be autumn and winter. So you'll get it for a good 6 months. And indications include premature babies with congenital heart defects, okay? Now, you can take a look at the NICE guidelines, which give a further few qualifiers, which is a question of whether the babies are stable or not. But you should at least think about children with congenital heart defects, especially premature babies, yeah, under the age of 1, at being of high risk of getting a high degree of mortality from bronchiolitis, yeah, or needing ventilator. So as a result, we give them palivizumab as prophylaxis, yeah, to further protect them. Okay, so that brings us to the end of this session. I think we've covered a fair amount of pediatric cardiology there. As said, this wasn't really meant to be a tutorial running through everything or going from the ground up. It was primarily assessing your ability to apply knowledge. And lots of you did really well in answering most of these questions correctly, so well done. But a quick recap over what we covered, and this should provide a good structure for people who do want to read up further. And it gives a good set of the basics. We covered acyanotic heart lesions. So in that case, we spoke a bit about the various septal defects and patent ductus arteriosus briefly. The 2 cyanotic lesions we covered were tetralogy of Fallow and transposition of the great arteries. We spoke about the principal obstructive lesion that you can get in pediatric cardiology, which is coarctation of the aorta. Okay, and I'd say at minimum, you should be familiar with these 3 things mentioned here. Syndromes of cardiac involvement, if nothing else, please know about trisomy 21 and the fact that they get septal defects, with AVSD being the most common. And then other ones you can know about are DeGeorge syndrome and fetal alcohol spectrum disorder, but there are a few others as well that we covered on the slides. We spoke a bit about murmurs. Things you might want to look up further are the 6 or 7 S's of pediatric murmurs. Yeah, and knowing that a diastolic murmur is always pathological. And then importantly, we also spoke about heart failure in pediatrics. And it's really important you guys know that how heart failure presents in children, and the fact that you need to check for hepatomegaly when doing a cardiovascular examination on children and babies, okay? So I hope that's been useful. And yeah, I guess for the live session, I'm here to answer some questions as well.